Good evening. So I'll be talking about that. We are time bad, so I'll be quite fast. So the truth is, the surgeons have the better side of the case. It's always easy for them. The anesthesiologist is always a tough tug of war with the blood pressures. Honestly, it's a nightmare to the anesthesiologist. And if you get a pheochromocytoma case for any other reason other than removal, the mortality is 25 to 50%. If you get it for an elective case, the mortality is less than 3%. The truth is, preoperative management is the most important aspect that changes the outcomes for these patients. If you don't really grasp the concept of mortality, the ASA classification, that's the American Society of Anesthesiologists, looked at the classes of status of the physical status of the patient, and what they actually found is that the patients that we work on most, those are the elective cases, have a mortality of far less than 1%. And yet a pheochromocytoma, which has not been diagnosed, and you end up having it on your table, which most times is an emergency, is going to have a mortality of nearly 50%. So that means that once you get that patient on table, everything is going to go south. Probably do CPR at the end. The truth is, everything that has been presented here is really based on limited data and mostly expert opinion. So we do not have any randomized clinical trials. What we really have is case series and case reports. That means that there's a lot of variation in treatment, especially on the preoperative end, to try and optimize these patients. It's nothing really concrete that we can use. And so what we really must rely on is the tumor physiology and also receptor pharmacology, and that's where we anesthesiologists have a very big role to play. However, fundamentals of the management exist. Yesterday, we worked on a case, so I felt like this ground round is going to be mostly about preparative assessment and how to manage these patients. So I thought maybe let's go through the case that we had yesterday, and then you can get a look. You can take a look at what was going through our minds as we're going through the case. Because most times the surgeons are using their hands, and anesthesiologists are using both hands and mind. So yesterday, a patient comes on our table. Of course, when a patient is on the table, it belongs to an anesthesiologist. And the BPs, starting BPs were 160 over 111 with a mean arterial pressure of 127. Now, honestly speaking, in some institutions, this is unacceptable. You can't have a patient coming to the table with such BPs. But we all knew that this patient has been well prepared, and we were wondering, why are they hypertensive in an upright position? Because we put them in that position for a certain procedure that you'll eventually see. So at that point, I engaged one of the surgeons in a conversation. Was the adrenergic blockade adequate preoperatively? Because that, we know, actually does change the outcome. Was the patient anxious? Because this patient had been in theater before last week and had missed surgery because oxygen pressure has dropped from this to the ground. And then the anesthesiologist had put the patient under, and they had to reverse and then cancel the case. Maybe she was afraid that that would happen again. And we know that in pheochromocytoma patients, even a little stress causes a surge, despite how blocked they are. So the question was, should we really proceed with the case or not? Well, based on the previous history of the patient, we decided to proceed with the case. To highlight the principles of preoperative management, you need adequate alpha blockade. It's the most critical element in management of these patients. And the goals are really to optimize the BP, the heart rate, and other organ function, because we know that when these patients get into a crisis, the lungs are going to suffer, the brain is going to suffer, the kidneys are going to suffer. And then the ICU doctors will have a hell of a time for that period that we get the patient to them. And then, of course, we want to restore volume, because once we put them on alpha blockade, we tell them to take in a lot of water and also salt so that they can build up volume. But also the alpha blockers cause vasodilatation that creates a relative hypovolemia. But also, we tried in this period to resensitize the alpha receptors, because there's been a lot of catecholamines coursing through their plasma. So there is no really, again, concrete literature that says do 10 to 14 days, but what we know that you must hit the targets of the alpha blockade. Never rush to operate, never. If you do, mortality is 25 to 50%, always remember that. So how then do you know that the blockade is adequate? And this is one of the questions that the residents always get when we do the pheochromocytoma. The thing that you must look at is, what does the patient tell you? The patient's complaints, when you put them on alpha blockade, what will they tell you? Things like diaphoresis is what you'll pick up, but things like, I get dizzy when I stand up. I feel my heart beating really fast. My nose is ever congested, and the way and when you examine them, what you find is that they're diaphoretic, they have clammy hands, okay? And then, of course, the tone of their voice has changed because their nose is congested. But also what you will find is, if you do investigations, usually you want to do a baseline investigation to look at the hematocrit. They usually have hemoconcentration because of the catecholamine surge. So when you give them alpha blockade and you tell them to take fluid, the hematocrit actually does drop. Usually into normal ranges, but then again they may be anemic, like the patient you saw at the beginning. So in the anesthesia department, I think something is missing here. Okay, so what happens in our department is Miss Fowler comes and lets us know she has a feel. And so what happens is that there's a lot of excitement, because this is one of the most feared tumors. Although we have demystified it, now the residents can do it without unattending. So what happens is that they form a team, about 3 or 4, form a WhatsApp group. And they call that WhatsApp group Team Pheo. With that WhatsApp group, they start reviewing the patient, giving updates to their senior residents, or if they have an anesthesiologist on board, they include them on the WhatsApp group, and they discuss the case up to the time of the surgery, distribute the roles, and after that, they go into the case. So intraoperative care, again, back to the case. This lady was hypertensive at the beginning, as you can remember. We gave her 2 milligrams of midazolam. That is a sedative drug, short-acting, quick onset. Within 5 minutes, it has already set in. And we would have loved to give fentanyl, but with the currencies of the hospital, we tend to run out of drugs. So we weren't able to give fentanyl. It's a drug that's about 100 times more potent than morphine, with nearly less side effects than morphine. And the BPs dropped to about 138 to over 75, and the heart rate of 96. She was a bit drowsy, of course, at the time. And then we also did that because we wanted to do a spinal anesthetic. And we tend to be very liberal with local anesthesia, because any form of pain will cause a sympathetic system stimulation. So we did a spinal. The other option that you can do. So what we know is that we have to anxiolyze our patients and give them analgesia at the beginning. And some of the drugs that we may use that are really uncommon and are expensive are dexmedetomidine. It's relatively new to Uganda, but it is an alpha agonist. Kind of mops up, helps reuptake of the norepinephrine, but provides analgesia, provides sedation. We didn't have that, of course. So we often do neuraxial blockade to provide adequate analgesia. What we know is that regional anesthesia or regional analgesia is slightly superior to IV analgesia. So we do an epidural block, and most times we don't do it in the lumbar area, we do it in the thoracic area, because the incision is at a level of about T7. And what we know is that the incision that the surgeons do, the surgeons never think about pain. We always think about pain, so we want to give the best analgesia for these patients. So they pull, they stretch the skin, they do everything. while we are trying to make sure that whatever they're doing has no consequence. So at induction, the general principles we want to follow is that we want to start magnesium sulfate. Now, again, there is no literature that confirms that magnesium sulfate is the best drug to use. It's not there. But different institutions use different protocols. Now, South Africa uses a lot of magnesium sulfate. You find that in India, like one of my seniors was telling me, they don't use magnesium sulfate. So, well, we don't know. So we usually bolus about 2 grams and then start an infusion. And then prior to induction, prior to intubating the patient, the BPs were about that, which is fine with us because what tends to happen is that when you intubate these patients, their BPs shoot through the roof. So you need to have them a little bit hypotensive before you proceed with that. So we gave the anesthetic drugs. We would have preferred to use a drug like Propofol that killed Michael Jackson, but unfortunately it was still out of stock, we would have wanted to. So again, fentanyl would have been a good option here. We had 2 attempts because the lady was apparently we didn't estimate well her required endotracheal tube size. She should have gotten a size 7, but she ended up getting a size 6.5, which was a bit interesting. So when you do more than 1 attempt, definitely the BPs are going to spike. So after we had done that, we decided to place an arterial line. Now, what I'm telling you is what most institutions will do. So arterial line is really going to help you with real-time monitoring, but we also placed a central venous catheter in the right subclavian vein. As you can see there, you have the arterial line wave, and we didn't have CVP monitoring at the time. That is the arterial line wave, and that is the BP. As you can see, there's quite a big discrepancy, but just because the arterial line is real-time. So laryngoscopy, that is probably one of the most stimulating times of any patient, both for hypertensive, pheochromocytomas, thyrotoxicosis, mention it. What we know is that there's a lot of physiological evidence to support this. There's a lot of observational studies to support this. And what we try to do for these patients is to give them as many drugs as possible to blunt the reflexes of getting hypertensive when we are intubating them. So we want to take them into a deeper plane of anesthesia. And if there are any undergraduates here who have been in another department, you better know what the deep plane is. And so we also want to use drugs like opioids. The stronger ones, that are much stronger than morphine. Fentanyl, remifentanil, that's 1,000 times more potent. Propofol, beta blockers, 5% lignocaine, and we use that IV, and we can also spray the larynx just to blunt the reflexes as much as we can. So the drugs that we often avoid are saxamethonium. I'm sure you've all loved the reactions when we give patients saxamethonium, the twitching they get, but we don't want to use this because it kind of causes a surge in the catecholamines. And then histamine drugs, we want to avoid morphine. However, our patient, we gave morphine, but intrathecally, which is in micrograms, that doesn't really cause histamine release. We also want to avoid ketamine and ephedrine. Ephedrine, we mostly use that to increase blood pressure, but it acts in an indirect manner to make you release more catecholamines. So patients with pheochromocytomas have a lot of vesicles that have a lot of catecholamines. You want to give them a drug like ephedrine. So there is still no literature that tells us that if we don't use gas and just use IV drugs, it's better. So that is total intravenous anesthesia doesn't really have any superiority over using inhalational vapors. So it depends on what you have. What I can tell you is if I use propofol and remifentanil that are very quick, very strong drugs and short-acting, I'm probably going to control the patient better than someone who is using the gas. But will it affect outcome? No. We don't know that for sure. So what we avoid is really ketamine, like I mentioned that. And also we want to make the patient normoglycemic because these surges increase the sugar levels. Most times we don't really have a glucometer to keep monitoring these patients. Arterial line, that is the basic structure in case you have no idea what I'm talking about. Like I said, it allows real-time blood pressure monitoring, but also prompt response. And we can now, I can confidently say that we can now actually use it for functional hemodynamic monitoring that I'll be talking about a little later on. We would like also to monitor the central venous pressures, especially for patients who have cardiomyopathies. That was me doing a central line so many years ago, it was one of the patients that had the Pheochromocytoma. And so functional hemodynamic monitoring, what we know is that when we use static parameters like blood pressure, the central venous pressure, systolic blood pressure, you see a patient is hypotensive and say give fluid. These parameters actually don't tell us much about fluid response, okay? When you give them. They can remain as they are, they can go up, and that does not mean that the patient has actually responded. So it's better for you to toss a coin than to rely on that. So right now what we can do under anesthesia with the current monitoring, we can do pulse pressure variation, and I will urge you to go, if you do not know about it, you can read about it, and stroke volume variation, and then the plethysmograph variation index. So these actually have a prediction of 80% when we use them. And it was the first time that we used the pulse pressure variation yesterday. It was wonderful that the resident actually saw that. And so just to show you, on the side there, you actually see the pulse pressure variation of 13. At that time, the vein had been clamped, and we are having swings. So patient was still paralyzed, and more than 13 means patient is fluid responsive. Less than 13 is not fluid responsive. But just because they're fluid responsive does not mean you give them fluid. But that's a whole big grand round of itself. And two critical points during surgery. Now this is where the surgeons are having a lot of fun, seeing the tumor while we are having a lot of chaos behind the curtain. And tumor manipulation takes up most of the time. Honestly, yesterday we struggled with the blood pressures, but the good thing with Samakombi keeps talking, so you keep being informed that what's happening. It's good for the surgeon to keep communicating, as you will see, because this requires a lot of teamwork. And also, when they ligate the adrenal vein, that is when you have all hell breaking loose before, then you have all hell breaking loose after. No momentary pause in what's happening. So that is the monitor of the patient with a BP of 233. That was the highest we recorded yesterday from the arterial line. Now, if you're using the non-invasive blood pressure monitoring, you wouldn't know what's happening. But that happened, and we were able to control that. And so most of the drugs that we use, we had magnesium sulfate running. We just increased the flow, and then labetalol, we gave that in increments of 20 milligrams. And you would like to have drugs like esmolol that are quick onset, short acting for that period of time. Because as you will see that when you treat these hypertensive episodes, the lingering effects of the drugs we've used make the patient hypotensive when they're done stimulating. And of course, we make the patient deeper, and we can use drugs like nitroprusside, but like Dr. Napagala said, it has the risk of cyanide toxicity. So treating that hypotension that happens after they are done stimulating, we want to use a drug like phenylephrine. That is a pure agonist for the alpha receptors. So it's safer than using ephedrine or using epinephrine, like I had explained earlier. So magnesium sulfate in pheochromocytoma, some of the articles that have been published, they're quite old. The BJA, of course, is sensible to know that they're quite old because it's not so common to have this condition. What they found is that magnesium sulfate is actually a good drug to stabilize these patients. And another one that was published in the Anesthesia and Analgesia Journal, these were by South Africans, found the same thing. The first one was an editorial, the second one was a case series. So these are the effects of magnesium sulfate. 4 of them, Dr. Tindi, the retired head of department, keeps asking about the 4 of them. And again, I urge the residents from anesthesia to know them. You never know when the question will come. Then the antiarrhythmics that we use, magnesium sulfate also acts to do that, but we always have amiodarone available, adenosine available, and the rest. So once they ligate, then you have no more supply of catecholamines. Then what's going to happen is that you're going to drop in blood pressure so fast. If you're not using the invasive, it's going to be difficult to keep up. And so again, open communication with the surgeon is very critical, because he did inform us that we are about to clamp the vein, and he went ahead and did that. But during that time when he was about to clamp the vein, we decided to switch the patient. We took the patient from a hypotensive state to a mildly hypertensive state, because we knew what was coming. We kind of release the level of anesthesia, bring them a bit to a lighter zone, and then we switched the magnesium sulfate, put on norepinephrine at that time. So once they ligated, this was the BP before ligation, and when they ligated, that BP dropped so fast within a minute to 60/40. And of course, we were ready for this, definitely. But, well, it's a bit of it keeps you on your edge. It keeps you on your toes. So at that point, the question was, the resident asked me, do we give fluid at this point? My answer was no. Why? Because we know what the reason is. The reason is that catecholamines have dropped. So what you do is put them back. And of course, the first instinct will be to give fluids, because you may not have the catecholamine that we had, but the first instinct should be to give vasopressor along with fluid. And this patient was previously anemic, and so we decided to give a unit of whole blood as a colloid to help the BPs come up. So right now in preoperative medicine and critical care medicine, we try to restrict fluid therapy, simply because so many studies have now been released that a lot of fluid actually has a high mortality for these patients. So we want to keep our patients dry, just enough to perfuse the body extremities, especially the brain and the kidneys. So most of the antihypertensive drugs that we use are noradrenaline, phenylephrine, and adrenaline after the excision of the tumor. What tends to happen is that yesterday we gave phenylephrine in a dose that we expected that it would raise the blood pressure. It didn't. We gave a second dose, 50, twice bigger. It didn't. We gave a third dose, 4 times bigger. It did. The options for that happening is you have probably downgrading of the receptors. So because you have too much catecholamines. And then magnesium sulfate also makes them not so sensitive to the drugs. And then principles, so keep open communication, sympathetic surges must be controlled well, short-acting drugs are preferred, and then adequate analgesia, and invasive monitoring, and minimizing hemodynamic fluctuations. Special circumstances, Ms. Fowler talked about this, and I will not delve much into that. Postoperative care, our patient is fine. What we know is that she delayed to wake up because magnesium sulfate and the drug we gave, cisatracurium, have a synergistic effect in causing prolonged neuromuscular paralysis. But it was fine. She woke up well. We extubated her in the ICU. And we always want to monitor blood glucose, but we are not really sure if monitoring the sugar has any benefit, because it's good to do it, but do they actually become hypoglycemic? Do they become hyperglycemic? The patient has not become hypoglycemic at any one point. Of course, they are now feeding, which is a boost for them. And they are drinking water. They had a meal today, and norepinephrine is about to be switched off. So in ICU, they usually stay for a very short time, about not more than 48 hours, unless they have comorbidities at the beginning. And we maintain adequate analgesia, vasopressor therapy, weaned off gradually. It shouldn't take longer than 24 hours, really, and normoglycemia and euvolemia. And in case of residual hypertension, you want to think about possibility of a residual tumor. She apparently, right now she doesn't have residual hypertension, but sometimes these patients actually get transient hypertension, simply because when you have a lot of catecholamines coursing through your bloodstream, even the nerve terminals that naphthalene, you know, the presynaptic membrane actually does take up most of that and then releases it intermittently. So in the first 24 hours, they actually get that problem. Pre-surgery ICU management, and this is the ICU care. Some of these patients will end up with us because of a hypertensive urgency or hypertensive emergency. So when it comes to management of these, it's really in the ICU, not out in the medical wards, which are really for elective or cold cases. And most times we want to support the organs, but the ABC principle remains paramount. Controlling blood pressure, what we do in anesthesia in terms of controlling the blood pressure is the same, almost the same thing that we do in ICU. Magnesium sulfate can be used. In some ICUs, in other institutions it's not used, but it's actually good to use it. And supporting organ function, if the lungs are failing, we go ahead and support with ventilation. If the brain is failing, we do neuro support. If the kidneys have failed, then we consider calling in nephrologists and starting possible dialysis, if it's that bad. Really, we have not gotten to that point yet. Close monitoring of the patient, definitely we have to do invasive blood pressure monitoring, and that was Team Pheo 2013. We are in 2015. Thank you very much.